So first we'll have Professor Eli Schwartz from Israel. He is the director of the Center for Geographic Medicine at Sheba Medical Center in Tel Hashmor, Israel. First introduced the field of travel medicine to Israel. His practice became the recognized center by the Ministry of Health of Israel for tropical and travel diseases. Dr. Schwartz, Professor Schwartz, is currently serving as the president of the Israeli Society of Parasitology and Tropical Disease and past president of the Asia Pacific Travel Health Society. He's a full professor, clinical, at the Saker Faculty of Medicine, Tel Aviv University. Having said that, let's start. So our first rock star for today, Dr. Professor Eli Schwartz from Israel. Please take it away, Doctor.
So thank you very much for the introduction. I will share screen.
Yes.
Okay, so as was mentioned, I'm from the Tropical Institute in Sheba Medical Center, which is the largest hospital in Israel. And for a long time, for several months, we are doing this study on ivermectin versus placebo to treat non-hospitalized patients with COVID-19. And this is a double-blind, randomized controlled trial. And now we are really at the final end of the study. So I will show you our results. It got the IRB from our hospital, from the Ministry of Health of Israel, and it's also registered in the clinical trial gov. So you have here the number. All people who want to follow it or to see more details, you can go and look into it as well. Now the study. The objective of the study was to see whether, we started to look for this study at early March last year. And we were looking for a drug which can reduce the viral shedding at the beginning, at the onset of the disease, because it may break the transmission chain. And this is the main objective, was really to see whether the ivermectin can do the job. We also thought about evaluating the effect of ivermectin on prevent progression of clinical disease to prevent this severity and the need for hospitalization. However, quite soon at the beginning, we noticed that more than 95% of patients do not deteriorate, and our sample size is not going to really help to give a solution for this aspect. So we are our main concern is really whether ivermectin can reduce the viral shedding. The study design, we are talking about non-hospitalized patients. And as we mentioned, randomized controlled double-blind trial. And the setting was unique, or maybe not only in Israel, but we have in Israel people who have verified diagnosis of COVID-19 and cannot be isolated at home. They are sent to dedicated hotels. And therefore, we thought that in this facility, it will be quite easy to recruit patients and to complete the study very quickly. That was kind of illusion, because people not really run to participate in any control study. They were looking more maybe for vaccine, but not for drugs. And therefore, it took for a long time to complete the study. The study was aimed to deal with adult population, everybody older than 18 years old. We didn't want to deal with children, because then we need the parents to sign the consent. And we didn't want to include pregnant women, because the safety of the drug is not well known. So everybody older than 18 can be included, doesn't matter what his medical situation. And the other point is that since we decided to look for viral shedding, asymptomatic patient could be included as well, because the main point is to follow them and to see whether the viral load is decreasing more quickly in those taking ivermectin compared to placebo. The other point which we thought at the beginning, to recruit the patients quite early during the disease, after the disease onset, and it means within 3 days. However, at least in the first wave of the pandemic, and the study was started at the end of our first wave, it took time. It took time until the patients decided to go to be checked. It was about 2 to 3 days, and then it took another about 3, sometimes even 4 days until they get the reply of the result of the nasopharyngeal swab. And therefore, to have patients within 72 hours became kind of illusion. And therefore, we extended it and we included patients less than 1 week from symptoms onset or from diagnosis for patients who had no symptoms. The intervention, we decided to give ivermectin for 3 days, and we decided to give it in the same, more or less the same dose that we used to give it for parasitic disease. It means 0.2 milligram per kilo. So you can see that people 40 to up to 70 kilo received 4 tablets per day, but for 3 days. And people over 70 kilo, they received 5 tablets, again for 3 days. The other point which I want to highlight, that in this study, it was double-blind with identical placebo. I'm saying it because some of the recent published data were done without a comparator of placebo, just standard of care, which it's more easy to be biased. And in some, at least in one study, which was done in South America, they did placebo, but the placebo was so easily be identified, so it was not really kind of a placebo. So here we're talking the same appearance and same taste for both ivermectin and placebo. The follow-up was for 14 days because at the early stage of the pandemic, the isolation time was at least for 14 days, and then people were asked to have 2 negative PCR tests, and therefore we decided to follow them for 14 days, and then by telephone to know what's happened later on until 1 month. And we decided to follow them with a repeated PCR testing every 2 days. We decided to start it on day 6. That means if they're taking the drug for 3 days, so we have to wait another 3 days and then to see whether the viral load is, whether the virus disappearing or at least significantly decrease. And therefore we decided to do it at day 6, 8, 10, etc. During the pandemic, it became obvious that after 10 days, people are no more infectious, and in many countries, there's no need for further isolations. And therefore, people left the hotels much earlier than was expected. And therefore, we added 2 additional measurements on day 2 and on day 4. I'm saying it because for these 2 days, which become later on very crucial, we don't have, the sample size is not big enough. Talking about the sample size. So we decided, or we calculated, calculated that on day 6, according to the data that we have from the Ministry of Health, about 90% of people still are positive. And we were looking about 25 decrease in positivity rate, which means from 90% to 67%. And for this, we found that we need 48 patients in each arm. So it's total 96 patients. We thought about people who will drop down, and finally we recruited 116 patients. Unfortunately, too many patients were dropped out because either we found them, we repeated upon finding them, allocated them in the hotels, we repeated the PCR testing, and we found many of them to be PCR negative. And some of them declined from the study. So altogether, the bottom line is that we have the final numbers are ivermectin 47 and the placebo 42 patients. Here's the reason why they were dropped out. Not so important now. Let's go for the results. The important point is that if you look to the comparison between the two groups, the ivermectin and the placebo, so the numbers are slightly different, but all parameters like age, how many of them were older than 50 or even older than 60, that the risk factor is increasing. How many of them have had other risk factors like diabetes, hypertension, etc. The gender, weight, the percentage of asymptomatic, all of them had a similar numbers. So you see there's no significant difference between the two groups. The other important and interesting finding is that the recruitment time post on symptom onset was also quite similar. And you see it took about 4 days, the mean time to catch them for 4 days from symptom onset. And this happened in both groups. So let's go now and see the results, the actual results. So here what you can see is the viral load. Usually you get results in CT value. There's a special way how to translate it to viral load. And here you can see in the red box, this is the ivermectin group, which is quite similar. This is day 0, quite similar to the placebo group. And then you see that when with time start to move on, you see that the ivermectin, the viral load, is decreasing more rapidly compared to the placebo. And you see it mainly on day 2 and on day 4 and day 6. Later on, you start to see that they became equal. And this just represents the natural history of the disease, that placebo, even without treatment, if there's no any severe complications, if there are no severe complications, they will be healed. And therefore, this part is usually you see that there is no any advantage for the ivermectin. The main advantage, the main change, you see it at the early stage of the disease. And that will teach us that when we talk about the practice of giving ivermectin, as soon as you give it, you may get better results. So this was the viral load. The main point is to see how many people become negative. And again, the cutoff of the machine, let's call it, is CT level more than 40. But this, to reach this CT level may take 3 to 4 weeks. However, during the pandemic, we learned more about the natural history of the disease, and we learned that in CT level of 30 and more, people mostly, almost 100% of them become non-infectious. And this is the most important part for the whole managing of the pandemic. You want the people, the infected people, to be non-infectious for the environment. So we decided to go and look for the negative sample at the level of CT value above 30. And now you can see what's happened. So if you see, we started from day 4 to calculate. Day 4 means 1 day after termination of treatment. Remember, the ivermectin treatment or placebo work for 3 days. So if you see the odds ratio, you see that all of them is about 2.5 or even more in favor of the ivermectin. Ivermectin is doing much better compared to placebo. However, in day 4, due to the limited number of patients, we don't get significant numbers. However, on day 6, which was the primary endpoint, you see that it's significant. Day 8, it's significant. And then later on, it's declining because, again, as we mentioned before, the placebo are doing quite well and heal themselves without any assistance from us. So this is the negativity rate, or we can say here that on day 6, we see quite clear the advantage of taking ivermectin compared to placebo. If we do multivariant analysis, we get the same answer, that we see that there is no any impact of the gender, no impact of age, weight, symptoms, yes or not. However, if you look to the giving ivermectin, it's give you 2.6 higher chance to be negative compared to placebo. So this is highly significant, and this actually was the point that we wanted to see in people being treated with ivermectin. The last point at this stage, we did Kaplan-Meier analysis, and we did it about symptomatic patients, so we can see the timeline. And you see here, this is the symptoms onset. Remember, about 4 days, it took them to reach to us and to be included in the study. And then here is the intervention started. And you see that within about 2 days after initiating treatment, you can see the difference. And the blue line is the line of ivermectin, which became negative much faster compared to the red line, which is the placebo. So this was the actually the main findings of this part of the study. As I mentioned to you, clinical deterioration, from the beginning, we noticed that it cannot be fulfilled, but just to show you, we have, for example, we have 4 patients who were hospitalized. 3 out of the 4 were placebo, compared to 1 of ivermectin, who actually was taken to be checked in the hospital a few hours after giving him ivermectin. So you cannot say even this related to ivermectin. In fact, after a few hours, he was sent back to the hotel because he so quickly recovered. There was 1 asymptomatic patient who switched to be symptomatic, and this was happened in the placebo group. So all these numbers are maybe kind of trend, but it's far from being statistical significant, and there's no doubt that there is a need to do a good study to see high-risk patients, whether if they are taking ivermectin, we can prevent the deterioration to hospitalization, need for oxygen, etc., etc. The safety of the drug. So actually, there was no safety issues in this cohort. We have, as you see, 3 people with diarrhea. 2 of them took the ivermectin, 1 with placebo. In both of them, diarrhea resolved within 1 or 2 days. And again, nobody really knows, it might be part of the disease. 2 patients has 1 to 2 days of rash, which also subsided spontaneously, and both of them took the placebo. So altogether, despite the fact that patients took slightly higher dose compared to the dosage that we use in daily life for parasitic disease, there was no any safety issues of this drug, which again, for us in the tropical arena who use this drug in almost daily life, we know that really there are no safety issues with the drug. So for conclusion at this part, ivermectin really demonstrated an anti-SARS-CoV-2 activity, which we wanted to show. And in this case, that it reduced viral shedding, it shortened the infectivity time, and it's really it's important for the public health point of view. And we thought that this will be the end of the study. However, luckily, at the end, toward the end of our study, something happened in our institute, and biosafety level 3 was opened. So we decided, since all the positive samples were stored in minus 80 Celsius, that we can try to see the viability of the culture and to see whether patients who were treated with ivermectin will have less viable culture compared to placebo. And we have to remember the viable culture these days is really the best surrogate marker for infectivity. So let's see. You do the in vitro study. You have these cell lines, usually it's virus cell, and then you take the medium which was kept stored, and you put a certain amount of it on each well, and you see whether you get, after 1 week usually, if you get any growth of the virus. we took only samples below CT of 30 because we know the experience for us and many others that in CT value above 30, the chance to get positive culture is almost none. And we checked the samples 4 and 6 days post-intervention. Now, let's see, it's interesting, it's nicely done. The way it is done, see, for example, patient number 147. On day 4 of intervention, we took nasopharyngeal swab and the CT level was 25, so it's significant positive. Then after being in the culture for, in this case, for 10 days, you see that the CT level dropped dramatically to 5. And for people who are not familiar with these numbers, as CT level drop down, it means that the viral load is much higher. So the viral load here is much higher compared the original the original number, original load, which was when we diagnosed him. On the other hand, if you see patient number 141, the same, the nasopharyngeal swab was taken on day 4, the CT levels was 23, and after being in the culture for more than a week, nothing happened, even slightly less. So this is a negative culture, this is positive culture. So now let's see the results. And you can see that on this study of 4 to 6 days, all the samples that we finally could retrieve them, you see that among the placebo group, 6 out of 18 tested positive. That means about 1/3, 33% were positive compared to ivermectin, which only 7%, 1 in 14 samples were taken. So this is not the end. We are hoping to get more results now for day 2. And we hope that the growing sample size will give much more significant results. But here you can see a solid data on the, I would say, direct effect of ivermectin on cell cultures. So if now we take a composite calculation, that means we take non-infectious samples, which is based on either CT value above 30, as we mentioned earlier, and taking also those below 30 but non-viable culture, all of these samples we know should be considered as a non-infectious. So we said we can see that on day 6, more than 90% of the samples become negative, and this is highly significant compared to placebo. So now, if I will conclude, I would say that beside the fact that ivermectin demonstrate an anti-SARS-CoV-2 activity, it really has a significant public health impact. It may block transmission chain, and therefore we should continue to do other studies, like, as I mentioned before, see whether it can prevent deterioration to hospitalization and the need for oxygen or intubation. We should further check it for prophylaxis. But I would say that based on my study, on our study, it significantly can shorten the isolation time. So I would say my dream now is that if we have a verified patient, he should be isolated and maybe take 3 days of ivermectin, and on day 4th to be checked. If CT value above 30, he can be released from isolation, and this is a major change. I mean, we have to remember isolation is a heavy burden for the economics, from the social point of view, and I think our study gave a good lesson, or more than a hint, that it might be with this drug we can shorten the isolation time. So thank you for listening to me, and if there are any comments, questions, I'm here.
Thank you very much, Dr. Schwartz. What a wonderful study, and thank you very much for the great results that you shared. We have a few questions if you're ready. A couple of questions are the following. One question that I'm looking at it here It is from Roberta, and they are saying that Dr. Schwartz, this study results was used for some public health mass strategy in Israel or not? Is it used to change any strategies?
I can say that fortunately in Israel, there's no need. I mean, due to the massive vaccine campaign, actually, we don't have cases now. And even the studies which I mentioned to you that I would like to continue, I can't do it these days in Israel. So in Israel, there's no, this is not the place to check it. But I mean, the rest of the world, it's still in under disaster situation. And I hope people will use it.
And by the way, congratulations for controlling the outbreak in Israel. So, of course, the whole medical community, the vaccination people, this you've done a great job. One more question here, that is from Laurie Patrick. Why did placebo cause symptoms?
Oh, it's happened many. I can't say that placebo caused symptoms. We said that people who were on the arm of placebo had symptoms. You have to remember that diarrhea can be part of the disease. Rash can be also part of the COVID disease. So nobody can say that it's really related to placebo. But absolutely, you cannot blame and say that ivermectin, people taking ivermectin had more kind of side effects compared to placebo.
Got it. Couple of more questions and possibly quick ones. One is from Edmund Fordham, and they are saying, what was the definition of asymptomatic patient? Positive PCR with no symptoms is likely a false positive unless low cycle threshold value, multi-gene detection, or confirmed on repeat. I note many dropouts were found PCR negative or on repeat.
No, first of all, you have to remember that positive PCR is hardly you get it as a false positive. To get false negative is very common, but to get false positive is uncommon. That's one thing. The second is you can ask how come the people who are completely asymptomatic, why they did check themselves. So usually the story is that one of the family member had the disease, verified disease, and then the other go to be checked. And then you find them, and many times the CT value can be equal to people with severe symptoms. And actually, I think there is a question about what is CT level. So if it's okay, I will briefly answer.
Definitely, please do.
CT means a cycle threshold. That means, I mean, the whole point of the PCR system is that you multiply, you start with a small amount of virus, you start to multiply it. And each cycle, you're doubling it. So if you need to double it many, many times, you get high CT value, but it means that the mass of virus that you started with was very, very low. On the other hand, if you have a high volume, high load of virus, there's no need to do many cycling until you find the positive results, and therefore low CT value equivalent to high viral load.
Got it. So thank you very much. One last question. So this question is also from an audience member here. Liver cirrhosis and ivermectin. Is ivermectin contraindicated, or should the dose be adjusted in a patient of liver cirrhosis?
It has metabolism in the liver, so I guess it should be modified. I must say I'm not familiar. Usually our patients don't suffer from end-stage liver disease, so
Professor Schwartz, I can answer that one. Yeah. The actually, I was going to talk about it in my talk, but the actual insert for ivermectin says that dose adjustment is not required in liver disease.
Excellent.
Okay.
So
thanks.
Thank you very much, Dr. Corey. And Dr. Schwartz, thank you, Professor Schwartz, thank you so much for your time. Thank you for sharing these study results, beautiful results. And once again, congratulations in Israel to be on the path for opening up the society back again. Thank you very much.